2018 glorious year. So thank you all for coming. Not only do we get a chance to review what's going on in 2018, we also get a very insightful view about some really interesting analysis that the HPC staff have been doing in terms of better understanding of the healthcare system of Great Commonwealth. Unfortunately, I have the privilege, but not necessarily a desirable privilege, of saying goodbye to Wendy Everett, who will be, I don't understand this at all, but she has chosen to leave the Commonwealth and to spend her, you'll be visiting a lot, but spending at least her legal residence, or moving her legal residence to California. So Wendy, you've been a great addition to the commission, and we will all miss you very much. My pleasure. Come back and visit as much as you can. All right, so we have the minutes of our September 27th meeting. Is there a motion to approve them? And a second? Okay. Now, are there any additions, changes, corrections anyone wants to make? If not, all in favor?
Aye.
Very good. So, David, if you would give us a summary of what we've been up to in 2018.
Great. Good afternoon, commissioners, and to the public. And first of all, I just want to say happy holidays to everyone, and just really a tremendous year at the Health Policy Commission. This is our 6th year anniversary. Our first meeting was in November of 2012, and in the December 2012 meeting, there was a vote to appoint me as executive director. And it's just been a tremendous 6 years of my life and career. So thank you, and I'm really proud of the work of this organization, of the staff, of the commissioners, and of the partnership with the healthcare marketplace and all of our stakeholders who dutifully come to all of our meetings and engage so much in our work and provide such thoughtful comments and input into the work of this commission, which all comes together to make it successful. So thank you, commissioners, for your time and effort this year. You have earned your paychecks. And truly do want to, your leadership is just so important and critical for the work of this organization. So this is our annual meeting, and so I'd like to take a moment just to reflect on the year and some of the work that we've been up to. So I'm very pleased to be joined at the table here with the Deputy Executive Director of the Health Policy Commission, Colleen Nelson-Meyer. And so as typical for us, we like to do we love numbers. We do the by the numbers of how we've done over the year. And so we'll just walk through a couple of slides just to remind ourselves of how much we've done this year, because truly this has been an incredibly busy year for the commission with a lot of very significant milestones. So Colleen, you want to talk to us about our public engagement in 2018?
Absolutely. So as David said, we're finishing up our 6th year at the HPC, if you can believe it. And I'm here to report on our biggest year yet for public engagement and transparency efforts. As you'll see from this slide, we've had 26 public meetings, which include our board meetings, special events, and our cost trends hearing. That actually tracks to over 50 hours of meetings on our YouTube channel for anyone who wants to go back and relive some of those moments. Our work has also been featured in over 400 stories in the media, over 100 different media outlets, and we've had extensive interaction on our Twitter account, which is a great way to follow our work. We're reporting that we had over 33,000 visits to our homepage alone this past year, which has been a huge spike over the first 5 years of our website's existence. And finally, we had our most highly attended cost trends hearing ever, with over 400 attendees in person and over 2,000 folks on the live stream, which makes it even more accessible and transparent that we can actually put all of our meetings up on the web and on live stream.
So at the beginning of the year, we consolidated and reformed our policy committees from the 4 different policy committees and down into 2 policy committees. And so the next 2 slides will just kind of talk about some of the highlights from those 2 work streams and policy priority areas. So the first is in our market oversight and transparency policy priority. Just a coincidence, but we do also, in addition to 26 public meetings, we had 26 different publications that we released throughout the year in terms of reports, policy briefs, including 5 of our online data point releases, which are kind of an interactive way to work with the data on issues of interest to the Commission. We had about 10 materials change notices that we reviewed. Did 2 rounds of registration through a provider organization program, totaling 56 organizations registered. And then I think, as you may all remember, we had 2 full cost and market impact reports that we released this year. The partners acquisition of Mass Ioneer, the final report we released in January, and then of course the extensive report on Beth Israel, Leahy Health. So over 300 pages of reporting just in those 2 cost and market impact review reports. On the care delivery and transformation side, happy to report that we had 21 new practices that joined the PCMH Prime program in 2018. So that program continues to grow. And we have our 17 certified accountable care organizations and released a couple of different publications highlighting some of the good work that the ACOs are doing here. Very excitingly, we entered in a new partnership with Mass Challenge Health Tech, which is an organization that connects with digital health innovative technology startups, essentially. And so working with them, we've been able to identify a couple of different digital health startup companies based here in Massachusetts who we're going to be matched with and connect with, and hopefully connect them to our grantees through our investment programs. So a great way to be able to leverage the ecosystem in Massachusetts around digital health to work with our grantees on some tricky challenge areas. So happy to report actually today, just this morning, we were matched with 3 companies, 2 of whom are in the substance use disorder engagement and treatment space, and one of which is really around helping consumers navigate where they should go for care in terms of urgent care, retail clinics, primary care office, or the emergency department. So areas of course, great strategic alignment with the work of the Commission. We distributed about $17 million through our investment programs this year, and then also authorized a new $10 million program for Shift Care, which is going to be launching on January 1st, all of those awards. And of course, the work of our Office of Patient Protection continues unabated. So a lot of big activities this year, a new grant program, a couple of CMIRs, a lot of new publications and ways that we're trying to engage the public in the work of the Commission. So I think we feel very proud of the work and that's been a very successful year. But more to come in 2019, and part of today's meeting truly is around presenting some new information on research and cost trends, and then hopefully engaging this Commission on where we want to go in the next year and begin that conversation. Any questions or comments on that? If not, we can dive right into the agenda for the day. So as I mentioned, really today's meeting is focused on a presentation of findings from our upcoming 2018 cost trends report. This is our seminal release, which looks at trends and specific data examinations into our healthcare system. As we've done in the past with the cost trends report today, we are just going to be presenting kind of the data findings and hope to engage the board in a conversation about what does this all mean and get your feedback and input on these analyses. And then have a conversation about where some areas of recommendation may be, and then come back at the next board meeting, which is going to be at the beginning of February, and at that point we would have a full written cost trends report for you to consider for approval and issuance. And there will be some back and forth in between that time period, but you'll have plenty of opportunity to look at the full written report. So no vote here today on the cost trends report. really an opportunity to kind of dig into the data, and David Auerbach and his team will be leading the bulk of this presentation. But as our traditional update, we have our material change notice slides. So I'll walk through these quickly. Since 2013, we've had 95 different material change notices to the commission. As I mentioned, we had 10 this year. Clinical affiliations continue to be kind of the #1 thing that we're tracking. Since our last board meeting, we had 2 MCNs that we elected not to proceed to a cost and market impact review. The first is a proposed joint venture between Reliant, which is a physician group in central Massachusetts, Shields Healthcare, and 2 orthopedic specialty groups. The joint venture is to operate a freestanding ambulatory surgery center in Natick. In reviewing this particular transaction, we did not see significant potential for cost increases. In fact, we saw some potential for some spending decreases. We don't know yet what this new facility will charge, but typically the freestanding ambulatory surgery centers have lower prices and lower facility fees than the hospital-based, than when these services are delivered in a hospital outpatient setting. And we do think that some of this care will be shifting from the hospital setting into this freestanding clinic. The second transaction that we received and elected not to proceed is much more of a clinical relationship between Dana-Farber Cancer Institute and Cape Cod Healthcare, where they're joining this Dana-Farber Cancer Care Collaborative. Dana-Farber will be providing education and support to physicians at Cape Cod Hospital in order to enhance their oncology services in that area. Again, did not see much potential for spending increases. This does not change contracting practices. In fact, the Dana-Farber doctors will not be practicing at Cape Cod. These will be Cape Cod doctors who will be providing the clinical services. So it's more of an educational and support network that Dana-Farber is putting together. So did not move forward on either of these 2 transactions. I'm happy to take any questions on these.
David, not on these, but just on, obviously the big issue that happened between our last meeting and this meeting is the agreement between the Attorney General and the BI lady, which everyone can have their own views whether it's good or not. But I wonder if you can comment on, does it have any implication for what we do, for any of our activities going forward, what things we need to pay attention to, or things we should think about at our annual meetings, or anything like that?
Before you answer that, David, thank you. You know, I think it would really be helpful for the commission itself if we got a much deeper dive of exactly what's in both the Attorney General and the Department of Public Health's final set of decisions. And particularly, I know that it's still being worked on in terms of the reporting and the role we play. So perhaps at the next meeting, David, you could give us some more detail. You answer my colleague here, but I think having a more detailed answer.
So the short answer, Commissioner Cutler, is yes. I think that we will need to consider carefully what our role is, and both with our existing tools at our disposal as this transaction moves forward, and where we do have the ability to access some new data and reporting as this transaction moves forward. But I think, to Chair Alton's point, worth probably a deeper dive and a more fulsome presentation at the next board meeting, where we can get into a little bit more detail about what that may mean, not just for us, but for our sister agencies as well. So we'll plan to do that. If that makes sense? Great. Okay. So with that, I'm going to ask the Research and Cost Trends team to join me at the table. And as they're joining us, just want to kind of emphasize again, we have about 70 slides of data here, some of which you have seen before, some of which is absolutely brand new to you and to the audience. And so I really do want to take this as an opportunity. This is essentially our primary agenda item for the rest of this meeting. So let's take some time, and where we have questions and comments, please encourage you to flag down David and the team, and we'll pause along the way to make sure that we're having some opportunity.
Let me add to that. Again, This is preliminary to our cost trends report, which we're obligated to provide in early 2019, I guess, in February or something like that. So as we're talking about this information, to the extent that they generate in you questions about potential recommendations moving forward, it's a good opportunity to, so it's not only of interest, the data is not only, well, that's interesting, it's what does it lead us to think about in terms of doing things. So.
Absolutely right, and the one final thing I would add to that too is, these are presentation slides with a headline essentially, and so also when we do the full written report, that is an opportunity to provide a little bit more context and nuance, and so encourage commissioners to help us think about when we do the full written report, how best we might want to frame up some of these findings in order to really make the story and the narrative fit together. But there's a lot here, and really proud of the work of the team. So with that, I'll turn it over to David Auerbach, who's joined by our Deputy Director for Research and Cost Trend, Sarah Sedowner.
Okay. So this presentation is going to be in these 4 broad sections, and with each section there are some subsections, and I will introduce each as we go. A lot of the slides in the beginning are things that we also showed in the cost trends hearing, some overviews, and then many of the ones as we get farther along will be a deeper dive that is a full chapter in the cost trends report, and we'll give kind of the highlights of that chapter. And I'll note who the researchers were on the team who did a lot of that work. So the first section is the overview of trends. Again, much of it was presented in the cost trends hearing, but some of it is new. And so here we go, starting with the benchmark trend. We all know that THCE grew 1.6% between 2016 and 2017, far below the benchmark. That's the preliminary number. And the average growth over the 5-year period now is 3.2% per year. And when we show that in a national context, and this is a slight update because now we have the true final number from CMS for 2017 to compare to, we are still below that national growth in spending in every year since 2010. And we can subdivide that by different payer segments in Massachusetts, and we see that in the blue, spending growth per enrollee, whether it's commercial or mass health or in Medicare, was below the benchmark as well. And the yellow is showing changes in enrollment within each of these segments. And you do see some shifts within groups there. For example, more people are going into Medicare Advantage from Medicare fee-for-service. But overall, per capita spending in each market segment is below the benchmark level. Yes. Oh no, please. Got it.
Great. It's great. First of all, it's an awesome collection of slides. I want to get through all of them. But as I was looking through this, something occurred to me, which is the cost increases against benchmark. That's very valuable. Is there a way at some point in the next year we can get a view of this in a somewhat more holistic way about the percentage of the of budget that's going to healthcare compared to other things? Like is the state budget expenditure for healthcare as a percent of the state budget? You know what I mean? Going up, down, or staying the same. Same for what's happened to the paycheck of a carpenter. Is the healthcare portion shrinking or growing? Because our benchmark still is above, I think, the rate of inflation. I'm not sure about that.
Yeah.
Anyway, that just is something.
It is growing. You're right. A couple of years ago we did show state budget growth of healthcare spending. We could come back to that.
Public and private sector.
Yeah. All your guesses are probably right.
But the idea here would be that it would only grow because of people, not because of additional spending per person. That is because we're below the growth of the economy.
We are indeed below the growth of the economy, and then also the growth of the state budget level.
Mostly,
Yeah.
mostly tax revenues increase with the economy. Tax rate approach. I think so. I think the economy is growing at 3%, tax revenue would grow at 3%, and then if healthcare is growing at 1.6, then absent more people, the state budget would be declining as a share of health spending, state health spending would be declining as a share of state budget. But I 100% agree, we should actually show that. We should actually show it.
Okay, the next slide is breaking down growth in the last 2 years by category of spending. And also showing below that the pie wedges the share of total spending accounted for by hospital inpatient, hospital outpatient, and so on. And as in the past, hospital outpatient in the light blue and pharmacy in the light blue are the fastest growing categories of spending for 2016 to 17. We will spend more time talking about hospital outpatient in this presentation and less on pharmacy, but we've talked about pharmacy a good deal. Okay, and so now when we take the spending growth just in the commercial market, again, we continue to be growing at about 2 percentage points below the national rate of commercial spending. And if we accumulate the total amount that we saved in the last 4 years compared to if we had gone at the national rate, it does amount to about $5.5 billion in the private sector in Massachusetts. And that lower rate of commercial growth has led to our premiums coming closer to the national average. They're still above, but I showed this before, but the top portion does show a divergence in recent years of the large employer market and the small employer market for health insurance, where in terms of large employer insurance, we're now about the 10th highest premiums in the country. For the small employers, it has grown above that, and we're the 2nd highest premiums for small employers. And that's in contrast to the premiums below, shown for the 2nd lowest cost premium in the connector, which does include small employers and individuals, and that is the 2nd lowest premiums in the country. So the opportunity there is clear, and a lot of small firms just don't know about the connector or are, for various reasons, haven't considered making that change, but it is open to them. So that's sort of a stark contrast. But in terms of the growth of those small employer premiums, we wanted to learn a little bit more about that. We don't have a definitive answer, but the next slide shows a little more detail on that market and what may be going on. In the top left, for example, you see that small group insurance is declining as a share of the commercial market, from 11% down to 10.2% in 2017, sorry, while the individual market is growing. There are some small employers who are dropping coverage, and probably some of those employees are finding coverage in the individual market. We don't know the full reasons for that. But to the right of that, you see administrative costs in the small group market are growing as a percent of premium. They spiked up in 2017 last year, which we saw from GIA. The bottom left is showing that fewer small employers are able to offer a choice of plans compared to other states and the rest of the country, only about 1 in 5 here. And we see, as we know, the high deductible penetration is now more than half in the small group market. So this reflects a number of challenges in that market. And we're still trying to understand what's really behind some of them.
Hey, David,
Sure.
it's so interesting how the difference between the price in the connector in the small group market versus not in the connector. Can you just generally give some reasons how that's possible?
That gap that I showed before it's a little bit overstated because of the actuarial value, but that bottom line, if it were apples to apples, would come up just a little bit, because the connector plans here, it's just showing not the portion that it's subsidized, but straight up 70% actuarial value silver plan. But in any case, this has been studied, and we know something about the structure of the connector is really very pro-competitive. Plans compete to be that lowest cost plan, the 2nd lowest cost plan, because they get a lot of enrollees who don't make a choice are automatically put into those low cost plans, so they get that market share. A lot of the plans in the connector are different from the plans you see in the broader market. They have a lot of the same folks who offer Medicaid managed care plans. They have a lot of experience in that market in offering low cost plans sometimes with narrow networks. A lot of them are eliminating coverage for some of the higher cost providers in the market. That's part of why. Is there anything else you want to add, Lauren? Yeah.
product selection. And actually we're seeing that behavior, that 20% is really based on consumer employee choice.
So Lawrence, then small employer goes to the connector. They just pick a level and then employees shop among the various products that are available that level's at. So the employees are really shopping and have a choice. So they don't have to.
Yes, that's correct. And there's an employer can pick from the vertical shelf or horizontal shelf. So meaning on the horizontal side, on the horizontal shelf, they can pick kind of an actuarial value, a metallic tier, and say you can pick across all of these different health plans products that are on this actuarial metallic tier, or they can choose the vertical shelf, which is essentially saying we are going to offer carrier X's products. You can buy up. We're going to contribute at the silver level. If you'd like to buy up to get, carrier X's platinum plan, you can, but you're going to end up paying more. So there's both options for them.
Thank you.
Small businesses are not
There's about 6,000 lives, which doesn't answer your question, but we redesigned it this year and launched it in January, and so we are slowly trying to get we're seeing a slow uptake, and so we are actively looking at ways to kind of attract businesses. But 6,000 lives is about double from the original launch back a couple of years ago, which I think we only saw about 3,000 lives. So we're making progress, but definitely there's more to be done, and it's a huge opportunity for small businesses.
Lauren, can you do the full defined contribution strategy? Just here's your money, here's the connector, go buy.
So that is an option that actually the federal government, through the recent guidance on 1332, has contemplated. I think we are looking at the implications of that and the potential loss of HPC. So that there's other factors at play and looking at the defined contribution. So I think it's an area that we're exploring given the recent guidance from the federal government, but don't really have anything to say beyond that.
But Professor Cutler, I think to your point, the kind of as I understood it, the vertical option does include some elements of that where you kind of say, we'll peg at the silver level. If you want to have the platinum level, the employees may
not all
pay the difference.
Uh,
That's right.
It's sort of one of the carriers.
Okay, so bottom line is a small business employee who moves from the business to the connector getting less complete coverage, or Lauren's argument is it more adapted to their needs? How would you frame it?
No, it's up to them. I mean, they're now facing a choice of plans, and somebody who might say, I would like to save 20%, and I can give up on having some providers in my network. I can make that choice, and somebody else might not want to make that choice.
But it's a choice of providers in the network, not benefit structure.
Right. The benefit structure is, as Lauren was describing, where you can then also choose different tiers and actually.
But silver would be the
And
same.
if they're doing silver, yes. And there's still modifications to that. That's
we had promised ourselves, and we had promised at the last meeting that we were going to do a deep dive on administrative costs, and at some future time. So I just happened to be looking. Maybe I should have looked at it sooner, but I'm looking at this one part of the bars about on the next slide. And I must admit, when things are counter to what I thought I knew, I first of all I question myself, but then I question them. But I usually question the data first. And this chart doesn't make a lot of sense to me. But as I said, it may be me. But for example, it has been traditionally known, quote unquote, that the administrative costs on small and individual groups are much higher than on big groups, because they have to go out and market individually, as opposed to, you take on a big group, you got one marketing and stuff like that, you don't have to do things. This chart, in fact, shows that there are higher administrative cost share premiums for large groups. Now, the gap is now really shrunk, which we want to understand. I don't get this chart. Unless there's something else going on that I'm not getting.
That's a good question. Yes, I have often seen that is usually exactly what your intuition. So I would focus more on the change over time, and as for the levels in 2015, I don't fully understand why that is, and it could be that a lot of this individual market isn't, pre-ACA, the individual market was hugely administratively costly, 40%. And I don't think you're seeing that in here, especially with the way.
I would look into the data before I'm going to give up on my theory.
Sure, we'll understand that.
I had the same, a slightly different reaction, but the same question here. Which is given that one of the major policy recommendations out of the cost trends hearings is to look at administrative costs and what we can do about them. Do you have any sense of kind of the proportionality aside for a moment, why we had such a gigantic increase from 2016 to 2017? Let's assume the data are correct. Do you have any hypotheses about what's driving that?
This came up in Chia's presentation from a month or two ago, when there was the suggestion that insurers had lost money in 2016 and were having to make up a lot of that hole in 2017. They might have just guessed wrong on the premiums and so on. There's an underwriting cycle and things tend to go up and down, and that was sort of all they had to say about that. You do see an increase in the chunk of administration that's just profit and loss.
But this
So
is
beyond that, I'm not
administration
sure.
plus profit.
Yeah,
This is what's left.
that's the stuff that is the medical loss ratio, one minus all that. Yeah. So there's a bunch of components in there, but I agree, there's more to understand in that picture.
We'll look forward to the deeper dive.
Great. Okay. So I want to just follow on from for example, the finding on growth in high deductible plans. And here we're just showing how one way that manifests is what people are paying out of pocket for care. And this is from Chia's household survey, 2014, 15, and 17. People reporting how much they pay out of pocket. And this includes not just deductibles and co-pays, but even if they're spending money out of network or any kind of healthcare spending out of their pocket. And that grew 23% from 2015 to 2017, with now about one in 5 people paying $3,000 or more out of pocket.
So what we want to link this to, I think, Stuart, is is there a trend in people reporting that because of cost they can't get access to the care they want or need, that this is highly consequential?
Yes. And for example, this slide which we showed earlier in the cost trends hearing, because of cost, about 1/3 of people in this low middle income tier are paying medical debt, are paying off old medical debt currently. And you see that group again is paying about 1/3 of their total income on healthcare. That's apparently affordable and probably not affordable. So
Yeah, the Commonwealth one routinely surveys, are you having trouble?
yes,
Because of good cost.
there's
We get
much more
state
data
level data.
we do. We have a lot of, and Chia reports that with their health insurance survey, and we could
Let's
have
take a look at that.
Quick question on the slide before.
Yep.
So when you say this middle bucket, the 139 to 89%, that over a third of their income is consumed by healthcare costs.
Yes.
But this dark blue the dark blue shade represents employer premium contribution.
Right.
Does that assume that if the employer wasn't paying that contribution, that it would be in turn actually income?
That they would get that money in direct income. Right?
Yeah, but
That's-
that's a good
it's
question. But if
and
that's the case, then you really need to add it to their compensation.
It is added to their total, so that money is in their denominator as well as in their.
It is in both sides.
It is. Right. But whether it's a 1-to-1, do I get every dollar of that back in wages? That's debatable. Most of it probably, but nobody knows for sure.
So, sorry, I was just pulling up the Chia report because there was a survey question on the kind of Massachusetts residents who reported that they had unmet healthcare needs due to the cost of care. And that's about 1 in 4 Massachusetts residents, so 25.6% of Massachusetts residents said they deferred care, needed care because of the cost of care. And 2/3 of those individuals had health insurance.
That repeat the follow year on year seems to be probably good.
We're almost at the end of this first section. We'll get there. And finally, I just want to make a point about, this is our care delivery slide, about the penetration of alternative payment methods. And we've again shown this before, but it's important to just remind ourselves that in the commercial market, it dropped in 2017 and was unchanged in Medicare as well. And the bar on the right is showing that we've made great progress in Mass Health, where right now the vast majority of their population is in ACOs. So that is really raising the overall statewide percentage of enrollment in APMs, but the lack of progress in the commercial market is a problem. As we'll show, we have providers continuing to live in the fee-for-service and the risk world, and it's very hard for them to justify reducing unnecessary utilization when it's just putting them in the red, and it's an uphill battle. So this is something that, we have limited numbers of tools, but it's really important that we continue that trend upward in terms of APM.
David, we've talked before about how the APMs tend to just nibble around the edges of risk.
And that is
So it'd be helpful if we had the gross dollars here to kind of put it into context.
It is hard to,
I think they're
yes.
pretty tiny.
yeah,
And it'd be, I think, useful for us to see year to year how the gross dollars change. And I believe
using the
that-
dollars at risk or in some
No,
way.
the actual transfers, I think it's part of what the payers have to report. How much of their deal with a provider group is paid as part of the bonus, fundamentally.
We can observe non-claims payments flowing, but we have struggled, right, David, with trying to track the true amount of risk that these providers are holding into these agreements in a satisfying way. We tried to ask that on our RPO survey, and providers struggle with putting down the numbers in a way that makes sense, but we're working on that.
Yeah, I would say, I think one of our goals for 2019 is to have a lot better, more detailed information about what exactly these contracts look like, how many of them actually have downside risk attached to them, because some of these contracts we know don't have any downside risk. And in the PPO market, where we have seen some premium uptake, I think we have an understanding that none of those actually have downside risk. And so not every APM looks the same. And for organizations who may say that we have a lot of our revenue under APM, what does that actually look like? How much risk are they actually taking? I think that will have a big influence on the incentives to actually change and transform the way that they're delivering care. So I agree with you. We have to do better than just kind of these top line numbers in order to understand how we're doing on this particular measure.
I mean, if we're gonna go deep on administrative costs, there are plenty of models in the country where providers assume the payer function. They take on both the clinical risk and all the financial risk. Kaiser would be the well-known example, and where admin costs are significantly lower. But unless we can frame that in terms of how the payers are selectively contracting with gross dollars, we won't be able to have an insight.
Okay. Second section, utilization. This will be in three subsections. The first one, we will again show some trends that you're often used to seeing. Okay. First, hospital use per resident. And Massachusetts is in the orange on the top. We continue to be above the national average in use of the hospital. And especially since 2014, we've been completely flat, whereas the US has continued to go down in terms of hospital use. So we knew this, and we find something interesting beneath that flat line when we take a deeper dive by payer on the next slide. Here we're showing hospital use by payer from 2014 to 17, with Medicare on the top, Mass Health in the blue, and commercial use in the yellow on the bottom. in commercial use of the hospital has actually dropped. The rate of hospitalization among commercially insured residents dropped 8% from 2014 to 2017. Whereas for the other payers it went up, and that's keeping our state flat in total. But that's an interesting finding that we'll come back to when we talk about, can we ever get a reduction in premiums? Can we ever get costs going down? We do see hospitalizations going down.
Dick, can you flip back to slide 19 for 1 second?
Yes.
Because I want to connect it to this. So you got the 4.4% drop in number of people covered under Mass Health. Is that right? Am I reading that correct?
That is right.
Who are those people, and does that partly explain the? I mean, is something going on here with acuity or the risk profile of Medicaid?
That enrollment drop is just 16 to 17. So I'm not sure if that's can be related to the hospitalization change. It is possible that those who dropped out were healthier or less active users of the healthcare system, and I think that's through eligibility changes that have happened.
Is the eligibility change
Related to that, yeah.
What happened? Where's the program integrity?
Yeah, it was program integrity, not eligibility.
Sorry.
Yes, yeah.
Well, where do those people go?
I mean, oftentimes there's a lot of churn between the connector care program specifically, and Mass Health. When income fluctuates, push them over the Mass Health bar, and they often end up on connected care program.
On what?
The connected care program, commercially subsidized. It's subsidized commercially.
Yeah, that's another number that would be useful to have, the churn. I know some states are up to 3 or 4% a month, so you have, you flip over 40% of the Medicaid population over the course of a year. It'd be nice to know how exactly we're doing year to year in terms of churn. That's all the efforts to outreach for disease management and so on. So it'd be useful how we're doing compared to other states.
I think there's something about that. It is hard to track people as they go from one segment of the market to another, but there are things we could.
Like slide 28 is probably more meaningful, which is just the overall for the company.
That's the overall
So I think that if we were interested in doing the smart metric, we should be the thing I would think about there would be the opioid issues. And are those leading to the differential trend between Massachusetts and some of them?
Why we went down a lot between 07 and 14. It's interesting.
So given with the drop in commercial hospitalization, we do see also a shift over this period longer into what hospitals people are going to and the concentration of hospital use in large systems. 2011, about 52% of commercial hospitalizations were in the largest 5 systems in the state. By 2017, that's up to 61%. You can see the membership in that top 5 shifts a little bit. And the final bar is showing if we repass that 2017 data, but in the world of where the BI-LAE merger has happened, that would be as high as 70% in the top largest systems.
One thing to just note on the kind of using the 2017 data, but then displaying it kind of in a post-epidemiology view, you do see that the who's in the top 5 shifts a little bit. So Wellforce comes into the top 5. It was interesting to me that South Shore Hospital has more commercial discharges than Wellforce or Stewart. One hospital versus those systems. They're all pretty tightly grouped together, but that is the data that South Shore actually has more commercial discharges than either of those 2 systems, and Stewart drops out of the top 5 in this recast world.
Now, we're talking about commercial.
Yes.
I think we need to be careful. Stewart is a lot bigger than South Shore. It has a lot of Medicaid, if I remember correctly. So I think I even got confused on that.
This is commercial discharges, yeah.
Okay, so some of our other statewide utilization trends. Our readmission rate, as we showed before, is not improved, even while the rest of the country has. As well.
Yes, Stuart suggesting we name this chart after me. That can be my going away present.
Although I should point out that there's been a lot of pushback on readmission. And, and I tend to be sympathetic to some of this pushback that really doesn't do a good job about the socioeconomic aspects of the patients. I don't know whether we can justify our higher rates of having more of those patients. So I don't want to get them off the hook. But I do think that I think these readmission numbers and their unwillingness on the federal government to adjust them is not a good thing.
And I would add here too, a credit to the Center for Health Information Analysis, who engaged a work group to re-examine how we're measuring readmissions, at least here in Massachusetts, and invited the Health Policy Commission and other agencies to participate in that. So that's been something that's been ongoing. They're going to be releasing their new readmissions report right before the holidays. I don't want to give away their headline, but it is not showing great improvement beyond what we see here. But nonetheless, I think there is an opportunity as a state to think about how, is there a different way of measuring some of these things? And I think returning to Ashish Jha and his presentation at the cost trends hearings also highlighted this as well, suggested that there may be alternative ways of looking at the data, maybe looking at total cost of care, for all patients 90 days after a hospitalization, not just were they readmitted, but kind of what is their overall experience post-hospital, may provide some different insights into, skilled nursing use facility, service intensity, things like that. So another area that I think we want to work on in 2019 is how best to account for this, and perhaps add some nuance beyond just the normal way that we've been counting readmissions.
I do have 2 comments on that as well. Number one is that adjusting properly for social determinants of health, it does matter when I'm comparing hospital to hospital, and it shuffles those rankings a bit. But here looking statewide, I don't think we suffer as a state from that adjustment. We're a pretty healthy state overall. I think this is true that we are doing worse. In 2017 data, the second note is that preliminary results from GIA suggest that we are continuing to get even worse in 17. So we will rename that chart with a new chart and see how it goes. Okay, a couple more utilization trends. Post-acute care. We showed this before, that our statewide use of skilled nursing or other institutional care after an acute care discharge, we did make progress on this in 2017. It dropped by about 1 percentage point. And most of the difference going towards home health. Routine on the top is showing discharges to home without formal post-acute care of any kind. And finally, something we track is the rate of discharges of community-appropriate care to community hospitals. And these numbers shifted a little bit when we refreshed GIA's corrected data from 2015 to 17. We actually kind of turned the corner from 15 to 16, where earlier we thought it was 2016 to 17. In any case, this trend of declining community-appropriate discharges in community hospitals stopped declining around 2015, and it's holding steady since then. So that's some mild positive news. Okay.
Well, positive, I think it's
I mean,
the right level.
Yes, talking about trends, not levels. The level could be very big, perhaps. Okay. So now we're moving into the second subsection within the utilization larger section, and this is on low-value care. And here I want to credit Laura Nasuti and Danielle DiCenzo for doing this work. And this is following on something we looked at a couple of years ago and we revisited through our new provider attribution model to get a better sense of how provider groups are doing on low-value care. And we added new measures and we improved our coding. So here's what we've done. To introduce you to the concept again, low-value care is procedures within different specialties where those specialties have gotten together and decided this is really not helpful, this is not necessary, in some cases even harmful, and have defined a set of services and procedures that meet this criterion. This is through the Choosing Wisely campaign that many of us have heard of. And researchers picked up the baton from that a few years ago and said, hey, a lot of these things we can actually identify in the claims data when these low-value procedures happened. Let's track that and what can we learn about it. This was first done in the Medicare data, and we and others have then ported that over to our commercial claims data to get a sense of how often is this happening in Massachusetts. So below you see a list of the services that we analyzed. There's 19 of them. They fall into different categories of screening tests, such as vitamin D screening, not necessary, not helpful in a general healthy population. Unnecessary preoperative testing, where often someone will just have a routine where they'll check off, do all these tests before surgery, like a cardiac stress test before a cataract surgery, not necessary, not helpful. Unnecessary procedures, unnecessary imaging, like imaging for uncomplicated lower back pain, inappropriate prescribing. So these are the sets of measures that we identified in our claims data over a 2-year period, and we are now reporting on the extent to which we find these procedures happen. So the key findings here are that between 2013 and 2015, about almost 500,000 Massachusetts residents received one of these low-value unhelpful services. That's about 20% of the people that we looked at. And the total cost of these services was about $80 million over this period. About $12 million was paid out of pocket. And this is a conservative measure of the cost. This is only the cost of receiving those procedures themselves. And oftentimes it's a screening test that leads to more follow-on tests and follow-on procedures that are, again, not necessary. And sometimes those costs can really add up, as well as the lost time for these patients of receiving things that they don't need.
So in the nature of thinking about this, $80 million as a percentage of our total healthcare spend is a small percentage. But the $12 million out of pocket is, I would suspect, a larger percentage of the out of pocket, because a lot of these procedures are being done by essentially healthy people who go in for an annual or biannual physical and just get it. So I'm wondering whether insurance companies or somebody could have a little card that they distribute to all of their, these procedures have been indicated by something, what's the name of the group, Buy Wisely, as really low value, just so you know. So if you walk in and your professional prescribes them, you may still want them, because a lot of people like to get tests. Makes them feel like their trip to the doctor was worth it. But at least they ought to know, because the truth of the matter is, how about split back 95% of the population has no idea.
That's a really good point. And, some of the insurers, in fact, have stopped covering some of these. I think Megan, I don't know if she's here, said that she got a vitamin D test that, the provider just continues to run as part of their habit. And then, boom, this one thing's up and the insurer's not paying for it. And you're suddenly hit with this, oh, this is the one you've got to pay for yourself. The provider didn't know, and these things, communication is not great.
I'm going to take this list.
Yeah, so the full freight thing gets put onto the patient. So just to build off your point, Mr. Chairman, part of the Choosing Wisely campaign, one of their arms is around kind of patient engagement and education and having activated patients asking questions with their physicians and engaging in a dialogue. And I would say, the numbers here are very conservative. This is just the top 3 commercial plans, very select amount of these services. And I would also, even on the out-of-pocket, I would just note, because of the claims lag data here, we're looking at data from 2013 and 2015. We know now in 2018, so many more of our residents are on high deductible health plans. And so if you're on a high deductible health plan, you may be on the full freight for some of these screens and tests that when you just went in seeking an annual visit, and suddenly what would have been a $20 general visit is now something much more than that. So I think these out-of-pocket costs are very understate what is probably the reality today in terms of what people are paying out of pocket.
plus the 19 procedures. I mean, this is a great model, but that's not the full list.
It's a typical
low value. That's an iceberg.
That's right. I want to reinforce that we're looking at, I think, a small section of diagnostic tests that are unnecessary, but well documented, to say nothing of unnecessary therapeutics. Without thinking too much off the top of my head, but there's certainly controversy in the literature about excessive physical therapy, chiropractic, recreational psychotherapy. With all due respect, it can take money. It's not needed for mild problems and take away from the people who need it. So this is part of what we can broaden and go to the literature and find places to go.
Yes, I think we are working with other researchers who are trying to expand this list for sure.
So other than publishing this list, do we have other tools to work with these providers so that they understand what's going on here?
Some providers have tools that we learn about and try to promulgate towards others. I don't know if we ourselves haven't really taken on to develop a toolkit, but there is a lot going on here that not everybody knows about, that there could be a lot of educational opportunities. Some providers put alerts in their EMRs, just as Stuart was kind of saying. Somebody comes in, this diagnosis, do not do this. Yes.
Something like that would really be important. I can tell you from personal experience from a year ago, physical therapy, right? And it was recommended that I have an MRI because of lower back pain. So I called the CEO of a hospital that I know, and I asked, should I have that done? And he said, absolutely, but only if you have it here. There's excellent margins. But the average person really doesn't know. And to have a guide would be great if that's something we could put together.
Yeah. Consumer Reports has worked with Choosing Wisely to do that. They have developed these guides, and I think people should. I don't have stock in that company, but I'm saying people are working on this angle, and I think it could get out there if we keep talking about it. I agree. And the next slide is showing, we were talking about provider groups have different levels of focus on this topic, and we do see variation by provider organization. On the next slide, we take the subset of patients that we've attributed to providers, 1.6 million, and we find differences by provider, as you see there, and this will be in the full chapter of the cost trends report as well. The percent of attributed members in these groups who have received a low-value care service varies by about a factor of 2 to 1, higher with Leahy, Midco, and South Coast, and lower Atrius, Reliant, and Basin, for example. A lot of that is due to the screening, the different rates in which they're using those screening tests. Okay, so there's more on this in the chapter. Okay, now turning to a different chapter where we talked about this topic at the MOAT committee meeting a couple of weeks ago, so I won't spend too much on it, but it's another topic of potentially unnecessary utilization. And this topic is admissions from the emergency department. So this is work done by Blyden Marcelot and Carol Trevino. Slide, there we go. And here we know that about half of hospitalizations originate from the ED. And we also know from the literature that there is quite a bit of variation, hospital by hospital, in the rate at which they do admit patients from the ED. And similar patients, which in some cases they could be safely sent home, in some cases they could be admitted. And the vast majority of those decisions are based on clinical factors, but not all. Sometimes it's related to what kinds of programs that the hospital might have or support the person might have at home. Can this person be safe at home? Sometimes there could be administrative factors. We've heard that in some cases it's the hassle and the burden is just easier to admit the person to the hospital than to discharge them to home from the ED for various reasons. So we wanted to explore this variation, at least to understand the extent of it and how it varies by condition and by hospital, before we will continue on with this work to try to understand why there is variation. So this is a project that is in the what stage. And here, so I just have 2 slides on this, but here we're showing that it certainly makes a difference what condition you have. For patients who have sepsis, they're almost always admitted to the hospital, and that's what we see in that box plot on the left. The percentage who are admitted to the hospital is about 90%, 95%. But then when you have a diagnosis like CHF or COPD, we see wide variation. These box plots, for example, for COPD, showing that 75th percentile hospital is admitting about 45% of its patients, and the 25th percentile hospital is admitting about 25% of its patients, and something like that. And so there's a lot more discretion here. There's also more variation in the extent of the acuity, but some of it is due to all those factors that we've talked about.
David, can I just make one observation, please? I'm not sure where it leads me now. I think, so as we think about the variation in the previous charts and the variation here, I think there are two ways to look at the impacts of this. One is, all organizations want to do better, and if you point out the ones that have lower rates, everyone will say, hey, what are they doing? Are they doing better than we are? Have they discovered something, and so on. I think what we know is from Wendy's repeated application of the Wendy ever chart that just doesn't happen. So the other way to think of it is as a prelude for using sticks. We encourage payers to say we're not going to reimburse for these. We encourage payers to go to the high cost folks and say, look, why are you doing this? We're going to reduce your pay, or we're going to do whatever, and so on and so forth. And then that gets into Chris's comment about we really ought to think about the nature of what's at risk and what are the metrics, and are the ACO contracts really good enough? Do they need to do more along X, Y, and Z dimensions or something like that? And I suppose to the extent it does lead me anywhere, it's to say that probably we need to think about going down that second route, because the first route really just hasn't been working. And so maybe one of our theme areas, in addition to the administrative costs or in addition to pharmaceuticals, whatever else we do, is to think about how do we evaluate where the alternative payment models are in terms of what things they are or are not incentivizing appropriately, and do we want to make recommendations or just point out things about those contracts where they could be better?
That sounds right. There are definitely documented cases where providers just knowing where they are on a metric are motivated to do
We're
change.
just not
And if that's
seeing that here.
and
We're just not seeing
there are
that.
strategies.
I mean, to be fair, we've seen it with some things, like, for example, in the CHART program with the care for people with opioid issues in emergency departments. I have a sense that we saw a lot of, hey, my organization doing, I want to do what they're doing. But then for a lot of these other things, it just doesn't look like we're seeing that.
I think it's a good open question for the board, frankly. In some of these areas where we're talking about utilization of services, and there are clinical decisions that are going into that, and different cultures potentially amongst these different organizations. What is the Health Policy Commission's role there? Or is it something more around what is the payment systems, the delivery system writ large? Are there more structural things that we should be encouraging, rather than trying to say, let's go to one individual hospital and try to tell them how to admit people from the ED, which doesn't feel like quite our role. But I keep that up as a conversation for the board in some cases.
Or should we, I think staring right at us, slide 37 is the differences that you see for Atrius and MacGyver are dramatic, and they reflect capitation contracts. Can we get them in to talk to us? And in addition to getting the numbers, I'd also point out that this is not a plug for Atrius, but it's a kudos to Atrius. They've started a joint venture with a company called Medically Home. This is for ER admissions, and they intercept patients in the emergency room and take care of them, including for some of these diagnoses, and not for sepsis, but certainly for some I've seen pneumonia, mild CHF, mild COPD, fever without of unknown origin. So there's a movement afoot. It'd be good to learn more, or for us to learn more about what they're doing.
again, it shows up the value of these capitated rates. Good point.
We do plan to look at some of these, hospital and post-hospital outcomes as a function of the primary care provider group. Definitely in our plans, and I think we'll see some of what we're talking about. And this is just admissions from the ED rates by hospital, and you see percent of people. There is variation, and you see the same kind of higher rates when you look condition by condition. They're correlated, and it's pretty much the same story. These are some of the key findings from that, and I'll just note, I won't review all these, but we wanted to be sure that hospitals that are not admitting a lot of patients, are they discharging unstable patients to home who end up bouncing back to the ED? And we don't see that. That's the last bullet there. Okay. Now we're going to move to the third broad section, which is on prices. And for the first subtopic within that, I'm going to introduce Sarah.
So we expanded our previous work on price variation to look at drugs that are administered by clinicians. Payment for these type of drugs doesn't always get as much attention as drugs that you get at the pharmacy, but they're an important part of the story. And before we get into the results, I want to acknowledge Rebecca Balder and Megan Wolf from the market research team who led this analysis with us. So we chose to look at chemotherapy. Oncology more broadly represents the therapeutic class that is the highest area of spending in both Massachusetts and the US. This is a very high growth area, and spending is expected to continue to grow at very high rates as there are hundreds of drugs in oncology that are currently in the pipeline. So we looked at chemotherapy drugs, which are typically administered by injection or infusion, and those are generally paid for under a patient's medical benefit instead of the pharmacy benefit. The way this works is that the provider purchases the drug from either the manufacturer or wholesaler, and when they administer that drug to the patient, the payer reimburses the provider for both the drug itself and for the administration. The prices, even for the drug itself, are negotiated between the provider and the payer, as other medical services are. So, so the way we approach this work is to look at variation in prices and utilization for these drugs. We focused on the drugs that are most commonly used, which we defined as drugs where there was more than 10 claims in at least 10 hospitals in 2016. We included just Blue Cross Blue Shield and Tufts Health Plan. Unfortunately had to exclude Harvard Pilgrim due to data anomaly issues. So that definition resulted in a set of 15 drugs for our study. And while we identified them based on claims, we compared prices using the unit of the drug for a more comparable measure. There are many units in a given drug. That exact number can vary for a number of factors. So we did a unit comparison. So this chart shows our results overall. This shows the variation by hospital in drug unit prices and variation in volume for our set. The x-axis here has the 15 drugs, and above each drug, each circle is a hospital where that drug was used. So first, you'll see a striking variation in prices. That's for each drug from the top circle to the bottom circle. And what you'll notice here is that there were 2 hospitals where prices tended to be highest across most of the drugs in the sample. We have one that's marked by a blue circle and one that's marked by a red circle. You also see a story here about volume. That's the size of the bubbles. And we see that volume is concentrated in the highest price hospitals overall. So more specifically, for 14 of the 15 drugs that we studied, the price per unit at the highest priced hospital was more than double the price of the lowest priced hospital, so a 2-fold variation.
Fair to say that blue circle and red circle probably acquire the drugs for a lower price.
I don't have any information on that. You know, that's not something that's
Yeah.
sort of publicly known. So I guess I can't speak to what the acquisition cost would be.
Why are you thinking that?
They're bigger, so they're buying more in bulk, so I wouldn't be surprised if they're getting
Got better just
better discounts. But I don't know, is, you know, it depends on if we're 340B possible. So
You said a server, I'm sorry.
I was just trying to figure out like if these are in any way correlated with cost or versus.
Yeah, I just, so a unit, what's the definition of a unit?
Well, what that means for each drug might be different, but it's basically the lowest, the smallest unit that gets its own payment.
So
So
it's what the
so many
bill
drugs.
master might say.
Right,
is
so
the
for
dose.
example, right, like on a Medicare fee schedule, they'll say, X dollars for every 10 milligrams of this drug.
And in the vertically, so under rituximab, the definition unit is the same for all those hospitals, we're sure about.
Correct.
So yeah, so and you see some on the far right hand side of the slide, which look like the cost per unit of those drugs is very close to zero. There is actually, and it's hard to, it's almost impossible to see in this graph, but there is still variation even there. But we're talking kind of within a very low price per unit. But the typical administration of some of these drugs may be 100 units. So that's one place where within the drugs, it's apples to apples, kind of within each drug.
And to get back to your question, Dr. Cutler, there's hospitals, maybe have different arrangements. Some might band together into different group purchasing. So in terms of 340B, we did another analysis that's not shown here, looking at the relationship between hospitals that do have 340B status and pricing, and did not find any relationship overall. So which might suggest that hospitals that do have 340B status are not necessarily passing on those savings. So just to again, without knowing the exact acquisition cost, it's hard to make conclusions, but at a high level. So just sort of wrapping this up again, a very clear relationship between highest price and highest volume, finding that on average those two hospitals had prices that were 71 and 92% higher than the median. And I think this is important findings because this isn't unlike drugs that the pharmacy. This isn't just a story about sort of high prices for manufacturers and middlemen. This is for drugs covered under the medical benefit. This area is a place where provider price variation and drug pricing really come together.
It's so important. I hope you consider a journal paper on this. It's really extremely important.
And with that, I'll turn this back to David to talk about the next area of price work.
So now we're going to broaden our look at prices, really to just try to understand some basic things about what prices are in the state and how they've been growing over time. And this is work by Katja Pankaj, Sweta Gadam, and tremendous help from Sasha Hayes Rostov and the rest of the market performance team going into this section. And we use Medicare prices as an important anchor and point of comparison, partly so that we can understand our prices relative to Medicare, just what are they, and we know something about that from other states and from the rest of the country as well. And Medicare prices are sometimes serve as actually a legislative set level, for example, for out-of-network comparisons and things like that. And we also just wanted to know how much our price is actually growing over time. Sometimes in the discussion around performance improvement plans, and we see prices going up 3 or 4%, and we wonder how can they fit under the 3.6% growth if they're just on the price, they're getting 3 or 4%. And we find we really don't understand these price trends very well. So here we use data from the Altair Claims database. We're using 2014 to 2016 data for some trends, and 2016 for the levels that we'll show. And this is from across Tufts and Harvard programs. So we're going to show prices, levels, and trends across categories. And one important thing to understand for the Medicare comparisons we're going to be doing is that our Medicare prices in the state are high already. On the inpatient side, Massachusetts has Medicare prices that are about 21% above the national average already. And that's partly because we have a higher wage index, which goes into those levels, and also because we have more teaching hospitals, which get a price bump for Medicare. In fact, as we're showing on the left, about 42% of Medicare discharges in Massachusetts were at a teaching hospital. That compares to 18% in the rest of the country. So that is about half of why our Medicare prices are high already. And even on the outpatient side as well, our Medicare prices are about 12% above their national average. Okay, so keep that in mind as we show these relativities. Okay, first on the hospital inpatient side, what are our prices for an average discharge in the commercial market versus Medicare? The difference for the median hospital is about 57%. Okay, so this is all discharges weighted by the acuity, and our average or median commercial price is 57% above the Medicare price. Okay, and you can see the width of that box is greater. Not surprisingly, the variation in the commercial prices is much greater, about 3 to 1 from top to bottom. 2 to 1, sorry. And then we can look at individual hospital procedures. Not surprisingly, we see some differences there around that 57% average. We see much higher relativities in something like septicemia, where we're 75% above the Medicare rate. Cellulitis is only about 26% above Medicare. Hip and knee is about 50% above.
So, David, before you go any further, obviously this is an area I spend a lot of time thinking about.
Yeah.
I'm just trying to think of what's a good comparison. At one level, you might want to say, well, all right, if we want to compare Massachusetts to the rest of the country, in terms of this differential between commercial rates and Medicare rates, which is becoming, at least in my mind, a big issue. So the average is about where we are. However, if you excluded the fact that our Medicare rates are higher, if you took that out, we would be above the average. But then you got to also take it out against the rest of the country. So I haven't quite figured this all out, whether by excluding the extra payments for teaching and the wage adjuster, which I understand, whether we would still wind up at about the average, or whether it would kick us above the average. So you don't have to answer the question right now, but if you think about it, you see what the issue is. The issue at the end of the day is whether our commercial rates relative to Medicare are pretty close, the differential to what's going on average in the country, or whether they're higher or lower. Because it has implications, particularly for what the commercial market looks like. But as I said, my mind is sort of jumping around, so I'm not sure I know the answer. Sure.
David, you started out, I thought, setting this up as Massachusetts having such a much higher proportion of teaching hospitals than the rest of the country. So were you framing it that way so that we could understand these differences, or is that just an association that is a fantasy of mine?
That was mainly helping us understand when we're showing a commercial to Medicare rate, those Medicare rates are higher. But it is in both of those. Our commercial prices are also affected by the high proportion going to these high priced AMCs. So maybe I didn't have as obvious a frame as you might have liked, but it's sort of a background fact to know. And yes, we've shown before that our commercial volume is tilted towards those higher priced hospitals.
For our parking lot issues, the hospital sector always looks at this and says, this is the cross subsidy, this is, we can't meet our costs on Medicare, so we have to charge higher commercial. I expressed some skepticism about that, but I'd love to dig in at some point on that point. What do we really know about that? And
It's the age-old battle.
it's the age-old battle, but is there any data or research, any way to sort of tell the difference between that? Is it just an explanation or is it a fact? I don't know.
It's a good summation we'll have some future time.
It's complicated because the overall profit of hospitals, profit rate of hospitals in Massachusetts is about, say, 3%, 4%, just like it is nationally. So you sort of look, and as an accounting matter, that's correct. That is without, if you took those down at the current level of cost, then they would lose money. I think the issue is that probably the way to understand some of the economics of the organizations is they spend kind of up to what their revenue is, absent a little to add to keep it in the bank. And so if we took away money from one pot, they would spend less. Another pot, my guess is the profits would wind up being about the same. So it's really an issue as to, if you do this, whether the things that they wouldn't spend money on when you took the money away were valuable or not, or, to come back to the earlier discussion, yet lower this by getting rid of the things that people obviously don't need. Then we can take those numbers down, and then we can, these rates can be closer, and you won't lose any money.
This is for later, but the other,
Again, I
the other
think
part of it
this
is for later.
I think those,
Yeah.
more discussions.
Let's have it.
Yeah, I agree.
Great. And now we'll just show these same differentials, but in other parts of the healthcare system. Here we're showing two common outpatient procedures. And these are divided between the professional portion of the cost that goes to the doctors in the orange and the facility portion in the blue. But the total differentials here are 61% for colonoscopy and 129% for a brain MRI, so even larger on the outpatient side. These are very big. Then we're looking at costs in the ED of your evaluation and management services. The professional and facility are separated out here, but the differentials on the professional side are especially big. Again, more than double what a physician receives for a professional E&M visit in the ED compared to a Medicare, what they would get for Medicare. And likewise, large differentials for a typical physician E&M office visit. For a new patient or an established patient, about 60 to 70 to 80% payment rates higher than Medicare. Okay, so that's the story on the levels. Yes.
So when you say commercial prices, are you saying the price that was paid to the provider, or?
Yes.
It is, okay, because
The
we've
allowed
heard
amounts.
anecdotally that some insurers will say, we no longer pay facility fees for E&M, for example. And so, I'm curious to know, did you look at the kind of reimbursement arrangements to get this data, or was it the charge or the actual amount paid by the insurer?
In this analysis, we tend to be very careful in all these comparisons between Medicare and commercial, where you're just showing the professional portion to professional portion, or facility to facility. It is true that in some cases, some payers may not be paying that facility portion for a visit. And so we're not averaging in that, and that is changing over time, as you say. So when I show the ED, it's going to be all in, but for these, we're comparing like to like, from commercial to Medicare. So is that satisfying? So it might not be a whole visit to a whole visit, but it's on the portions that are comparable.
And for these visits, this is just professional.
This is just the professional portion here on this specific chart.
I hate to do this. I just want to remind people we have a hard stop at 2. for the whole thing, and we'd like to finish this part somewhere around Q2 or stuff like that. And there are a lot of good, interesting information, and I'm as responsible for the time. I'm telling this to myself, but if you're listening, that's okay too.
Okay, I do want to make sure we get to the final section. So, okay. So that was a discussion of the levels of prices in the state, and we'll just show a little bit on the growth between 2014 and 2016. This slide is showing commercial inpatient price growth in the hospital. Here it's separated by category of care, and this is growth over the 2-year period, 14 to 16. We see in maternity care 6.4% growth, 6% for medical, about 4% for surgical, and so overall inpatient prices have risen about 5.2% in the state from 14 to 16, and that's higher than the rate that Medicare has grown by, for example, at 3.3. When we look at the cost of an ED visit, here it's broken into the components of the facility piece, the professional piece, and then the other things that happen to you in the ED, such as tests and diagnostics in the yellow. And combined together, the growth in the cost of an ED visit is about 12% over this period, from $1,024 to $1,142 for an ED visit. So double the rate of the hospital growth. And finally, we just want to show, putting this all together, what does this all mean for costs? You know, we have this price growth, but at the same time, we showed you that hospitalizations, the rate is going down. This is just in the commercial arena on slide 58. So we're showing from 14 to 16, what is the rate of change in the different components that add up to hospital spending? You see discharges went down 6.6%, but we didn't save any money on that because prices went up 5.2 in the blue, and actually acuity went up 4.2%. And whether that's real acuity or coding acuity, it's hard to say. But the combination of these three factors led to an inpatient spending growth that we see in the TME of about 5.3%. And that exceeds the growth in inflation over this time period, which was low, it was about 1%. So here's a way to put all these factors together to show the implications of this price growth in preventing us from realizing cost savings from the decline in use of the hospital. And this slide summarizes what I just told you. Okay. All right. In the last section, we're going to try to quickly put all of this together, the trends in prices and utilization, and looking through our lens of provider groups and variation in spending by provider group. I'll start with a couple of slides on TME, which is total medical expenditures for patients attributed to these provider groups, and we now have a 5-year trend. And note that these are just HMO or POS patients who select the PCP and we contribute to these groups. And we're only showing data for Blue Cross, Harvard Pilgrim, and Tufts insured members. And one thing you notice about this graph is that the different provider groups, there's sort of a convergence from 2013 to 15, and then they're spreading out again from 15 to 17. That is real and it's true. And part of that divergence, you can see, is led by Partners at the top, whose total medical spending has really grown from 15 to 17, which I'll show in the next page. Okay. This is unadjusted TME, and we'll talk about why it's unadjusted also on the next page. So there are some differences in the health status of the patients across these groups, but they're not large. These are big groups. But here's something that we see over and over again, especially when we talk about PIPs, that this is showing the 2-year cumulative growth in spending at these provider groups from 15 to 17. And the blue line, the blue dashed line, shows that there's about 10% growth in spending on average across all of these groups. Some are over 10%, some are under. But when you adjust that for health status for these risk scores, the average is about 0.5%. All of that growth goes away when you adjust for the health risk. And as we have learned and continue to learn, nobody really thinks that the entire Commonwealth is getting 10% sicker over this 2-year period. A lot of this is related to coding, it's related to EMRs, and the PIPS program runs off of those beige figures, not the blue. And if you are under 3.6% on the beige, you're not going to get identified by CHIA. So it does cause a challenge for that program. So now I want to introduce our final section talking about those differences that we just saw in total spending. And what do we know about that? Why is that? We're going to use the rubric of the patient attribution that we talked about last year, where we take everyone in the HPCD, we identify who is your primary care provider. If you're an HMO, we usually know that the insurer tells us. If you're in a PPO, we use the same Medicare attribution models to figure out where you're getting your primary care. And we attribute those providers to their medical groups. And then we can compare group to group based on what's happening to those patients in the claims data. We showed last year that there was wide variation by provider group. And for example, especially it was quite clear that patients whose providers were in AMC-led groups, such as partners, their spending was much higher. It was about 20% higher than if your PCP was in a physician-led group. And this really mirrors what much of the literature continues to find about the physician-led ACOs versus the hospital-led ACOs. The spending is just lower in the physician groups. And a lot of that differential we showed was in hospital outpatient spending. The total spending difference was on the order of 20%. So what we want to do here is take that next step and understand, well, A, we were a little bit worried that are the patients attributed to some of those provider groups just sicker? And we want to make sure we're not seeing just that. But we also want to narrow down to some really nice, clean comparisons of similar groups of patients. For example, we'll show a diabetes cohort where it's a very homogeneous group of patients. They're the same across provider groups. We kind of know what sort of care they should get, and we can even compare them on quality measures to learn not just about cost and spending, but about quality as well, and put the whole picture together, what we've been talking about. So that's what we're going to do. We're going to use the 2015 APCD and create 3 sub-cohorts of patients, and then show how they compare based on what provider group they're in. And this shows the 3 cohorts. There's a healthy cohort of 500,000 patients with no chronic diseases at all, a cardiometabolic cohort where you might have either cardiovascular disease, hypertension, or diabetes. And then finally, we'll spend most of this on the diabetes cohort of 10,000 patients who have diabetes and no other conditions. And we're not going to show every provider group, but to simplify this analysis, you see that pie down there. We're just going to contrast 2 subsets of patients. If your PCP is in an AMC anchored group versus if your PCP is in a physician-led group. And we will show you the individual providers that make up those subgroups in a couple of slides. Here I just want to show you some top-line data comparing these groups. What you have is, for each of these 3 cohorts, some data on the AMC anchored group and the physician-led group, those patients. And I want you to look at the risk scores, for example. You can see that those risk scores for these groups of patients are almost identical. So we feel we have a nice, clean sample of equivalent patients. The average ages are similar. There's slightly more in the physician-led groups or in HMOs. That seems to be a feature of those groups, and that's not a problem. And in the final column, you see the spending difference. One thing we wanted to see was when we narrow down to these similar patients, those 20% spending differentials go away. No, they don't. They stay, and sometimes they get even larger. So the first test was that, yes, these spending differences are real, even as clean and apples to apples as we get these patient groups. Okay, and now Hannah is going to walk through some more of the detailed uncovering of why spending differs based on what organization I'm in.
So we began by looking into the individual provider systems that make up the AMC anchored and physician-led groups that we'll be following throughout the remainder of this presentation. And we see that overall spending is higher for all AMC anchored groups of each cohort. So we deconstruct overall spending into 4 major categories, and we see that hospital outpatient spending is the largest driver of spending differences between AMC anchored and physician-led organizations that mirrors previous data points that we've shared. On this figure, we see hospital outpatient spending in the yellow segments towards the bottom, and the difference in hospital outpatient spending amounts to around $1,000 in both the diabetes and cardiometabolic cohorts. So given that we know that hospital outpatient spending is higher and some of these spending differences might reflect differences in site of service, we sought to investigate that.
So this slide demonstrates that there are certain services that can be performed in either a physician office or a hospital outpatient department setting. Again, that phenomenon of site of service that can have a major implication for price. And even when we account for differences in professional spending, we still see that spending remains 50 to 60% higher in AMC anchored groups. So we sought to investigate this further, and we looked at the proportion of services that were provided in a hospital outpatient department or percentage poverty. For a set of common ambulatory services, we can identify major differences in the percentage of services that were delivered in the hospital outpatient department. So that means that if you are in an AMC anchored organization, you're much more likely to have these services delivered in a setting where you will incur a much larger price for them.
And I'll just say to Lauren's point, in the majority of these cases, there is a facility fee that's attached to that HPC visit. Not always, but in this case, we'll be capturing whether that is included or not, just depending on what the payer's practices happens to be.
So we've covered site of service a bit, and now we'll shift our attention to utilization. In this figure, we're comparing utilization rates across all three cohorts stacked on top of one another. And any bar to the left of the center indicates higher utilization in an AMC anchored group, and to the right indicates higher utilization in a physician-led group. Oh, sorry. Thank you. Again, to the left is higher in a physician-led group, and to the right is higher in the AMC group. And we see that utilization is generally higher in AMC anchored organizations, with the exception of visits to primary care physicians and primary care providers and preventive visits in the cardiometabolic and diabetes cohorts. So given that we know that spending is a result of both price and utilization, the next two slides will show the percentage difference of utilization in yellow and the percentage difference of average price in blue. The first slide is for the healthy cohort, and overall we find that utilization and price tend to be higher in AMC anchored organizations for these individual procedure codes. The differences are larger as they pertain to price. Similar to the previous slide, except these are results for the diabetes cohort, we looked again at price and utilization, and again found much larger difference in average price. So we've established that spending is higher in AMC anchored groups, but are they receiving higher quality care? So to begin to answer this question, we start by comparing some other measures of utilization for the diabetes cohort alone. And we see that individuals in physician-led groups have lower rates of inpatient stays, ED visits, and potentially avoidable ED visits.
And could we just go back for one moment to slide 74? Kind of on these prior two slides, you have called out in a box that the AMC's paying 38 to 40% more for a particular test. If we just tie this back to David Cutler's query about for the physician administered drugs, are we seeing some effect of being kind of the size of the organization being able to negotiate discounts? Were you able to understand why these large academic medical centers with such extraordinary purchasing power are paying that much more for tests? Are they actually, is that what they have to pay to get the test, or that's what they charge the insurance company?
It's the price they're paid by the insurance company for those tests.
Oh, so it's paid for, not paid by. Got it. Okay, big difference. Thank you. They charge more. Got it.
Yes.
Really makes sense.
And so on that point, exactly, we're looking at two HEDIS process measures for comprehensive care for individuals with diabetes. We see similar utilization rates for these recommended monitoring tests, specifically HbA1c tests for glycemic control and albumin lab tests for kidney and liver function. And although they receive similar volumes of these tests, AMC anchored groups again charge much more, 38% for an HbA1c test and 69% for the albumin lab test. And so finally, we considered overall system performance on these same process measures for quality of diabetes care, and we find that AMC anchored organizations do not score better on these two measures. So we don't see any evidence of higher quality care despite higher prices in AMC anchored organizations.
questions about that. Just to summarize, the 20% differential in total spending that we saw before is still there, even when we isolate to very similar patient groups, and it's driven by hospital outpatient. We see differences in price, utilization, and site of service that are all contributing. And when we look at quality of care, there's no discernible difference. So, just to summarize, there is high value care available in the Commonwealth, and in terms of the cost driver, people aren't going to it. So, to the extent that they could be. So, with that, I'll turn it over to Steve.
We ran through that last piece pretty quickly. But again, I think it is confirming something that we have understood for a couple of years now, that your PCP and the organization within your PCP operates and is a part of the relationships those PCP have seem to have a tremendous impact, downstream impacts on overall spending experience of those patients, the utilization, the price, where they're getting care. And so, as I think a couple of years ago, the Attorney General had suggested, maybe we should think about when patients are selecting their PCP as a maybe a point at an inflection point where if patients are going to provider groups or primary groups that have these downstream high value, maybe there could be some that they could share in the benefits of that. So that's something that we've been continuing to think about, and this is confirming of that continued hypothesis. I think it also is just continuing to show that the high use of these hospital outpatient departments with their higher costs and facility fees is just a major characteristic of the way care is delivered in Massachusetts. And that again is an area where we have, the Commission has suggested in the past that we perhaps pass some restrictions on the ability to charge those facility fees in hospital outpatient departments, or to have site neutral payment, such that for some services there doesn't get to be the double bonus when you are at a hospital outpatient department. So continued area of focus and for our work moving forward.
I do want to follow up on that. If you go back to slide 70, it's interesting that in a number of situations, the amount of money that's going to the professionals is actually lower in the AMC anchor than it is in the physician-led, which, both in labs and in radiology, that's clearly the case. And so it just reinforces, your last comment, David. It really is in the facility fees. And then you get to the whole issue of the expense of the hospital and whether it's justified or not. So one suggestion, David, as one of the things we don't look into, but I think we need to look into, is the cost structure and the margins of our facilities and our in other words, what we tend to look at from a patient-centered cost, as opposed to looking at it the other way. Our hospitals will say, yeah, we charge all these things, but we're not making any money, and we need these costs, and we say, well, are they really your costs? So I'm not actually going to talk. It's something that we don't talk about, but it's really the elephant in the room.
I know we're short on time, but I just want to follow this up with, this was a spectacular presentation. And
did it just for you.
Well, then from the bottom of my heart, thank you. The amount of work that has gone into this, and I think, for me particularly, all of the questions that were generated from commissioners on follow-on work that we need to see done in order to make progress in these areas is an incredible tribute to the quality of the work that went into this, and I really congratulate the whole team. This was sensational. One of the best presentations I think we've ever had.
Thank you. So we are so David, why don't you just put this in context of what we need to do with this for the report? Will we have an opportunity to talk about it again before the report?
So we plan to circulate the full written report to commissioners after the holidays. and we'll have an opportunity for feedback on the written report, including the recommendations. And then at the February meeting, we'll spend the bulk of our time probably just focus on those recommendations and ensuring that the commission is comfortable with those.
Go back over.
But we do have a few minutes here. I only have one piece of business which I can get through relatively quickly. But if there are other feedback,
Here's a quickie. First of all, a great presentation, Hannah and Sarah. Another variable in the equation that I think would be useful for us to understand is the employment model. The trend of the last decade has been for physicians to sell their practices to hospitals. It's an unequivocal trend. It's gone from 35 to 65%, something like that. It'd be useful to know as we look at the physician organizations, whether they are independent or whether they are employed. And the subtext there is, these are the best of times, let's say. I'll leave it to the economists to amplify on that subject. But in good times, right, it's all growing. I had a conversation with a retired CEO of a $5 billion system last week. He said that he expects that the physicians are going to bounce out as soon as the recession hits, whatever that is. David Stewart, I'll ask you to
I can't tell you.
tell us.
I can't.
But when the recession hits, those physicians are going to bounce out of the hospitals, out of the big hospital systems. And so that's, we're talking about a dynamic process here, as uncompetitive as it is with fixed prices, lots of regulation. So it's something to keep in mind as we try to project where it's going.
Yeah, we have tracked that in the past, and it's really an important dynamic to keep on.
Any other comments or feedback? Well, look forward to chatting with you offline in the next couple of weeks because there was a lot to digest and to go through here. So I appreciate all the questions and comments along the way. So before we end the meeting, I do have one final bit of just business of the commission to go through, which is a consideration, a vote for approval of a contract. Contracts over a certain threshold I bring to the board for consideration and approval. This is a contract for an evaluator for our new shift care investment programs, a specific segment of the shift care investment programs. Evaluation, we think, is one of the core things that we need to do as part of these investment programs in order to understand how the program was implemented, what were the results and outcomes of these investments, and where we're making significant multi-million-dollar investments, we need to be able to understand, did it work, what worked about it, and to be able to spread those learnings as much as possible. So, and we also happen to have a statutory mandate that we do evaluation. So for this particular contract, you may recall in the Shift Care Awards, we did have a specific track that we had 9 awards for, which was around initiating opioid use disorder treatment in the emergency department and working with hospitals and emergency physicians to get people connected to medication-assisted treatment or pharmacological treatment in the emergency department and then connect them to outpatient settings of care where they can continue to receive treatment. There has been a national model at Yale New Haven which demonstrated very positive results in terms of engagement and adherence to treatment, lower mortality. And this is really a new emerging model. Some of you may have read there was a Boston Globe Spotlight Series article about this model or just earlier this week. And also here in Massachusetts, there was legislation that was passed this year, which is really trying to push a lot of hospitals in this direction. So we're right on the cutting edge of doing this, and we have 9 hospitals that are going to be working on implementing this model. And so we thought there was a great deal of value in doing one centralized evaluation for all 9 hospitals, kind of as a cohort. And here, especially with these hospitals where, as you can see on the slide with the logos, it's a pretty diverse set of institutions. These are urban and rural academic medical centers and community hospitals. And while they're all kind of going to be doing the same general model. They're also going to bring each of their own little flavors to it. And so we do think this is really ripe for investigation. So we went through a process of selecting an external evaluator. We posted a procurement. We had 7 bids for evaluation, and the staff, and with some subject matter experts, including Commissioner Cohen, read the different applications and weighed in. We had a different number of different factors. And so the proposal and the recommendation from myself and the team is to move forward with an award with Brandeis University to conduct this mixed method evaluation of these 9 hospital programs. The award cap is $600,000. This is supported by the Distressed Hospital Trust Fund. So this is not out of our standard budget, and was accounted for in the budget earlier this year. Represents about 10% of kind of the total amount of money that we're going to be spending on these awards, which is a good marker for when we think about how much to spend on evaluation. So I have, what's my disclaimer that I have to say good?
The disclaimer is under our statute when one of our commissioners is affiliated with an entity with whom you're seek to contract, we just make that statement public and acknowledge it in our minutes.
So yes, we have acknowledged that in our minutes, and Chair Altman did not participate in this.
I didn't even know we sent in an application. But I did, even though I've been instructed by General Counsel that I can vote, I think I'm just not going to vote. I'm going to refuse myself. So, but I reserve the right. That's something to do that, but I'm not.
So Commissioner Cohen, I don't know if I can just put you on the spot just to say, yeah, I know you read this application. And
I did. I think Brandeis brings a lot of experience, particularly in the substance use field. I think as well as data collection and analysis. And it was, I read the 2 final proposals, and it was clear to me that this was a better proposal. So I would actually move that we approve a contract of no more than $600,000 to carry out the shift care evaluation.
Second.
I just have a question about the length of time of the contract. It just seems really a long time for the review process to June 2021 to get back. So is that the timeline where they're going to report back?
yeah. So the length of time for the performance of these awards is 18 months. I think one of the things that we wanted to have as an advantage in this particular evaluation is we wanted to have our evaluator brought on earlier when they're launching these programs in order to help get some baseline data. And then will be with us essentially throughout the entire 18 months and then beyond that in order to get the data. So this is a multi-year contract. Commensurate with the fact that the programs themselves will run for a year and a half in the middle.
Where does the program end again? So I can remember that.
So they'll be ending mid-2020. And so then we would expect to have the findings at the beginning of 2021. So I think there was a motion.
All those in favor? Aye. Oppositions? Abstentions?
Great. And we are proud to announce our public meeting calendar for 2019. Obviously, there may be some changes, as there always is, but we'll try to do our best to stick to this. Thank you, commissioners. Thank you, everyone. Thank you to the teams who put a lot of work into today's presentation. And I hope everyone has a very wonderful, happy holidays and a great New Year's. And we'll see you in 2019.
Very good. Thank you, David. Thanks, staff. It's great. The meeting is adjourned.